Good morning, everyone. Am I audible? Yeah. Okay. So, not a great attendance, but I think that's testament to the fact that Dr. Chakani had a great party last night. So, I hope not a lot of people have headaches, and they'll be joining us shortly. So, I'm Akhil. I'll be talking briefly about how I approach a patient of back pain. We run a pain clinic at AIMS, which runs 5 days a week. We also have a fellowship program, 1-year fellowship program. So we have at any time at least 8 fellows going through with us. So whenever we have back pain, okay, whenever we have a patient coming in with back pain, it's important to know what exactly is back pain, right? So any pain and discomfort in the back, obviously between the costal margins and the inferior gluteal folds, that includes the buttocks also, that means, okay, is back pain. Just because it does not, back pain does not just happen above the iliac crest, happens below the iliac crest as well. So it's important to note that. Okay, and also back pain can be associated with leg pain or without leg pain. Different differentials if there is leg pain. If the severity of the leg pain is greater than the back pain or vice versa, then we have different differentials to go down. We'll discuss that shortly. Okay, so what is the problem, right? Now we all know, many of you are rheumatologists, some from PMR, some from ortho, and some from pain like me. Back pain is a big problem, obviously. In any pain clinic, we have at least 3 or 4 back pain patients being referred to us from orthopedics on any given day. So obviously it's a big problem. Now this study was published in Lancet Rheumatology in 23, and they said that they suggested there are 609 million people affected in 2020. So obviously a huge number. Okay, that's almost out of 7 billion people, 609 billion, half a billion people affected with back pain at any time. By 2050, this number is projected to increase to 843 million. So again, a big problem. This leads to, obviously a patient with back pain cannot do their normal daily activities, whether they are a housewife, whether they are working professionals. This affects the economy of our country, of the world. And disability from back pain is a big problem as well. We have many patients coming in from the army or the armed services for disability certificates because they have back pain, medical rest, disability certificates. So it's a big problem, which we have to tackle head on. In India specifically, at any time, annual prevalence is 51%, lifetime prevalence 60%. That basically means that 2 out of 3 people will have back pain during their lifetime. So again, a huge problem. I may have 60% chance of back pain developing during my lifetime. So this lady walked into our clinic about 7 months ago. This was a 61-year-old lady referred from orthopedics with back pain and knee pain. When she came into our clinic walking, first impression, she was obviously an elderly lady, obviously in pain. She had an antalgic gait. She was clutching her back, and she was trying to avoid putting weight on her right knee. She was accompanied by her daughter or daughter-in-law, I don't remember, and she was obviously overweight. So overweight, obesity is a big problem in our population, especially people coming with knee pain and back pain. So what was the brief history of this patient? We'll go through that quickly. So she had low back pain in the midline. Okay, this was slightly, when asked specifically, the pain was slightly off the midline towards the right side. This was insidious, gradually progressive, started 4 years ago. And the character was dull aching type. It was not a sharp shooting pain which you would encounter in a radicular type of pain. She also had complaints of pain in the right knee, which was a sharp pain when she put on that particular knee. And on questioning, she said that her back pain affected her more than her leg pain. She had leg pain. The complaint started initially with leg pain, but 4 years ago she started developing back pain as well. And now the back pain was much more than the leg pain. Interestingly, the pain was radiating to the right hip and the buttocks. Okay, so basically around the sides of the hips and the buttocks. The pain was not radicular in nature. This is an important point to note. Was associated with numbness and tingling. Again, numbness and tingling, immediately your mind goes towards maybe there's a nerve root compression. Like I said, 4 years. The pain was exacerbated by sitting, walking, and exertion. Any kind of activity exacerbated the pain. Even sitting did not reduce the pain. Her pain was reduced only by lying down, or when she took over-the-counter pain medications like Flexon. The numerical rating score severity of the pain was 7 out of 10. So obviously this was severe pain. She was in pain, living through pain. She was not able to do her daily living activities, and this was compromising the quality of her life. On history taking, she had morning stiffness present. This stiffness went away as the day went on. She did not have any pain in any other joints, interestingly. No history of night pains, excessive weight loss, loss of appetite. These are obviously, if any of these were positive, you would immediately start thinking about maybe there is some other constitutional systemic illness, maybe there is a malignancy going on. No history of trauma, fever. Again, these are all red flags. We'll discuss this later as well. And most importantly, whenever you have a patient with back pain, please ask about bladder and bowel involvement and whether there is a sensory or motor deficit, which she did not. So quickly, this is obviously the lumbar vertebra going through what can be the problem areas. The problem is that all of these can be pain generators. None of the structures in this diagram are innocent. You may have longitudinal ligaments which may give rise to pain. The disc obviously can give rise to pain by impinging on the nerve roots. The canal, the spinal canal can be shrunken and can compromise the spinal cord. The pedicles, the transverse processes, and the articular facets. The articular pillars are one of the most common causes of pain in the low back. So again, like I said, everything can be a culprit when it comes to a pain patient, a back pain patient. Vertebral causes of pain are common, probably the second most common. The pain is typically central in nature, axial pain, does not radiate anywhere, can also be facet. The origin can also be from the facets, the superior and the inferior articular facets, can give rise to pain very commonly, probably the most common or the second most common causes of pain, especially in osteoarthritis. Discogenic pain, again, a deep-seated pain. Discogenic pain can also have radicular pain components as well. So if you have a patient with radicular pain, you always have to think about discogenic origin of the pain. Myofascial, very common, especially in the younger age groups, not so common in the older age groups. Myofascial is, again, a superficial pain, can be elicited with palpation, and happens typically with movement, not at rest. SI joint pain, again, osteoarthritis, very common. Lots of rheumatological conditions manifest as SI joint dysfunction. This kind of pain more common with walking and sitting. In the early stages can be relieved by lying down, but as the disease progresses, the patient does not get relief from lying down as well. The patient tends to sleep on the non-affected side in the lateral position to give rest to the affected side. Coccygeal pain, again, common in young females. Typically, they will say that they require multiple pillows to sit on. This pain is not present when they are walking or doing their activities, specifically when they are sitting. So, in this age of work from home, lots of people coming in with complaints of requiring multiple pillows to sit while they are doing their office work. So, again, this is an up-and-coming problem for us. And nerve root, radicular pain, like I said, can be associated with spinal canal stenosis if it's bilateral, or if it's unilateral, it's probably more because of a disc. So, radicular pain. The important thing is that the radicular pain is always dermatomal. Okay, the patient will rarely ever say that the pain is all over the leg. The patient will be able to specify you where is it. Is it at the back of the leg? Is it going towards the greater toe? Is it going towards the fingers, the toes, besides the greater toe? So it's important to elicit the history when you have a patient who complains of radical pain. Where exactly is the dermatomal distribution? Because if the distribution is not dermatomal, it is not radicular pain. There are other conditions which can have limb pain, leg pain, which is non-dermatomal in origin. So again, facets. Facets, interestingly, facet joints have complex innervation, as we'll see in a few slides. They can manifest with dermatomal pain, and the darker shades like the buttocks and the front of the thigh, They are the more common manifestations of referred pain when you encounter a patient with facet joint disease. But it is important to remember, since it has a complex innervation, there is a big overlap when it comes to the referred pain. So you cannot, with any confidence, specifically say that which facet joint is the culprit solely on the basis of the referred pain pattern. Okay. Again, sacroiliac joint. This is a deep-seated pain, typically towards the sides of the thighs and deep in the groin. Okay, the patient will say that I have pain on the sides, non-dermatomal in origin, and deep in the groin. Okay. Myofascial pain. Again, all of us, I'm sure, have suffered from myofascial pain at some time or the other, most commonly in the back. This is elicited by any activity and by palpation of the affected muscle. If it's a hip myofascial pain, it can be elicited by adduction or abduction of the hip, depending on which muscle is involved. Again, non-dermatomal in origin. So, like in any history which we have learned from MBBS days, associated complaints are important. These are not to be missed, because in case any of these are positive, you might have to think about some other causes of pain, some other deeper systemic issues which the patient might have. Okay, bowel bladder dysfunction is a big red flag. Motor weakness, sensory disturbances, these are all red flag signs. Claudication. Claudication can be, especially in males, elderly males who have been smoking all their lives, you have to differentiate between vascular claudication and neurogenic claudication. Neurogenic claudication typically happens immediately. Once the patient starts moving, the pain happens. Vascular claudication takes about, takes 10-15 minutes, maybe if they have to walk 50 meters or 100 meters before the vascular claudication manifests. Also, the neurogenic claudication can also be precipitated by art tests, like asking the patient to bend forward or extend their back. The neurogenic claudication can manifest, not so with vascular claudication. Other joint involvement, obviously, being rheumatologists, you know the importance of other joint involvement. So if there are multiple joints involved, there are other symptoms present at the joints, swelling, tenderness, etc. You have to think about some other rheumatologic disease. Then it's not purely back pain. The patient needs further workup, need biomarkers, maybe HLA-B27, CCP, things like that. Past history, trauma. Again, trauma is a red flag. The patient has had a recent history of trauma, and the trauma correlates with the kind of pain the patient is having. You need to go in for imaging immediately and try to involve the other specialties like neurosurgery or orthopedics earlier than usual. Okay. Comorbidities. Again, most of these patients are obese. As a rule, most of my back pain patients who are elderly female, they're all obese. Obviously, multiple factors, not to say that we are trying to blame them, but they're all obese, and some amount of counseling regarding weight loss is useful. Although there is no role, absolutely no role for weight loss medications in such patients. Okay. Red flags. Again, like I said, very important to remember these red flags. Please keep an eye out and ear out for these red flags. If the patient has any history of fever or worse pain during the night as compared to during the day. I mean, normally back pain patients have pain during the day, they are better at night. If they have the change in the pattern, then you need to think about what else is going on. Okay, saddle anesthesia, basically perianal anesthesia, compression of the sacral nerves. Could be leading to cauda equina syndrome. Again, think about going for imaging early. Bladder bowel dysfunction, incontinence. Again, females generally in our country, elderly females don't have access to healthcare as much. So many of these patients have stress incontinence. Okay. Important to differentiate between stress incontinence, urge incontinence, and just complete loss of bladder control, which you will probably see in a red flag when you're coming to any spine pathology. Okay, again, family history, I mean, not directly important towards your management of the patient, but again gives you an idea about where the problem could be. Smoking, almost 70% of male patients with back pain have a history of smoking in the last 5 years. Either they are chronic smokers or they have recently quit smoking. So smoking is a big risk factor for the development of back pain. Pain assessment, again, these are all tools which are freely available. We typically use numerical rating scale. ask the patient how much your pain is out on a scale of 0 to 10. It's an easy to understand tool, and our patients are able to respond to that. Wong-Baker is typically used in children. They point to which face, what kind of faces they're feeling exactly right now. So again, Oswestry Disability Index is a good tool to see the progress of your treatment, okay? What we do is whenever the patient comes in for the first time to us, we ask them to fill this questionnaire. Easy to fill, we have Hindi versions also available which have been validated. So easy to fill, and we track this disability, the score as they come to our clinics on every visit. So it gives us an idea whether our treatment is working or not and how they're progressing. So whenever, again, examination, I'll quickly run through this examination. Whenever
your time is up actually.
Okay. All right, so I'll skip this. I'll just go to the more important, this one. So range of motion is important. In our patient, this patient had decreased extension and elicitation of the pain when I asked the patient to extend. That's typically what's known as facet loading. You ask the patient to extend and rotate to one side, and this will elicit a pain on the affected side. So this was positive in our patient. This you can take a photograph. This is quite a nice indicator. If the patient has a predominant back pain and it increases with flexion, okay, probably is discogenic or myofascial. If it increases with extension, it is probably facet in origin. Okay, predominant leg pain, again, if it bends forward, worsens, herniated disc. If it worsens on extension, it's probably a spinal canal stenosis. So easily available online, lots of tests. This is 3 out of 5 is diagnostic for a sacral joint disease, okay. So in our patient, the only test which was positive was a facet loading. Everything else, the straight leg test, the Faber compression, everything else was negative. So this probably pointed towards what is known as a facet joint syndrome. Okay, the patient also had right paraspinal tenderness present at the L4-5 interspace. If you want, you can take a photograph. This is just a rough, based on a meta-analysis, a criteria, diagnostic criteria about the different etiologies of back pain. Sacroiliac joint disease, again, 3 out of 5, the tests which we mentioned earlier. Disc herniation, straight leg positive test has to be positive. If it's not positive, then you have to think about other diagnoses. Investigations. I particularly do not like to get investigations done on the first visit. Usually these patients already have a chest X-ray, which is fine. Like sir said that, in elderly patient, you always have to think about malignancies and bony metastasis. So an X-ray will give you an idea about whether there are any obvious bony metastasis present. Okay, appropriateness. This is the American College of Radiology. Like I said, appropriateness is important. If the patient is coming to you for the first time and there are no red flags and has not been previously managed, please do not get any MRI or CT done or any advanced imaging done. If the patient has red flags or has been coming to you for some time on conservative management and is not improving, it's appropriate to get some investigations done. Again, there's nothing new for you, just to get an idea about if anything else is going on. So management quickly, these patients have to get NSAIDs, okay, we start them on etoricoxib. Muscle relaxants, if there is myofascial pain, I did not start this patient on muscle relaxant because they did not have myofascial pain. Antiepileptics like pregabalin or gabapentin, quite helpful in back pain conditions. Studies have shown that they are quite beneficial. Vitamin D, multivitamins, that's like, vitamin D deficiency is so prevalent in our population. It's important to replenish that as well. So after she came back to us after 1 month, she had minimal response to the medications, not doing very well on the pain medications. So we said that since this was a facet joint problem, seemed like a facet joint problem, let's do a diagnostic medial branch block. Very important, the facet joint disease can be easily diagnosed with the diagnostic medial branch block. Okay, like I said, the facet, suppose this is the L4-5 interspace, L4-5 facet, this is the L4, L5. The L4-5 is innervated by the medial branch of the same level, and also a descending branch from the upper level. Okay, so whenever you're targeting a facet joint, it's important to target both the nerves, the same level and one level above. Then only will you be able to completely take away the pain innervation. and you might have a proper diagnosis of a facet joint disease. So this is a fluoroscopic image, oblique image, obviously, of the lumbar vertebra. That if you can appreciate, this is a Scotty dog. Scotty dog is what we like to call our little oblique views. This is the superior articular facet. This is the inferior articular facet. This is the transverse process here. And this is the needle. This is a spinal needle which is going at the junction of the superior articular facet and the transverse process. This is where the median branch hooks and goes towards the midline.
Akhil, try to bind up.
Yes, sir, just finished. 5 slides more. Again, so we gave a little dye just to see the dye spread. The important thing to remember in a facet joint block is that volume is very important. As little as possible, always less than 0.5 ml. So after giving a diagnostic block for her, she had more than 50% relief for 3 days. So we gave only lignocaine, no steroid, nothing else. So this was a purely diagnostic block. She had good relief with the drug. So we scheduled her for a cooled radiofrequency ablation of the median branch blocks, both levels. So this is, again, as you can see, the lead. Same level. We did a cycle for about, I think this was 60 degrees Celsius for 150 seconds at both the levels. And she had good pain relief. This was 7 months ago. She came to our clinic about 3 weeks ago. She had good pain relief, sustained pain relief. So happy with the progress. And yeah, that's it. And I think one of our co-speakers will talk about exercise. Important to have exercise, not in the acute phase. Obviously, if it's a chronic pain, back pain, then exercise is extremely important, and it has been supported by multiple RCTs as well. So can be multifactorial, a systematic approach is required. Step by step, please do not rush into multiple therapies at the same time because it will only confuse the matter. And the right treatment for the right patient is extremely important. Thank you.